Hello, I am Dr. R.K. Joshi, Senior Consultant at Indraprastha Apollo Hospital, New Delhi. Today we are going to talk about chronic spontaneous urticaria. So first I will start saying what is urticaria. Urticaria is a disease of heterogeneous etiology. That means there are multiple factors which can lead to this kind of problem. So how does it present? Generally we do get wheal formation, which is a lumpy erythematous red lumps on the skin which stays only for 2 to 4 hours generally, and they disappear spontaneously, but they do replaced by new crop of these lesions, so they come and go. In some patients not only wheals, but they can associate it with more deeper inflammation and reaction, and that we call it as a angioedema. Fortunately, rarely we do get involvement of the mucous membranes and the respiratory tract, and that leads to what we call anaphylactic reaction, which is real severe. So this disease can start with only a few skin lesions to a fatality leading to the respiratory choking. So one has to be very careful what we are dealing with. Now to say what is acute and chronic. Acute means that this disease is within 6 weeks duration, but when it passes 6 weeks we start calling it chronic urticaria. So it is an arbitrary sort of classification, but it does work in practice way. Now there are two types of acute spontaneous urticaria as well. One is called allergic in nature, that means IgE mediated hypersensitive reaction. On the other hand, the second one can be a non-allergic in nature. When we say allergic in nature or IgE mediated, the common causes are infections like bacterial infections, commonly respiratory tract infections, sometimes the viral, and sometimes even the parasitic infection. The second cause is food, and these foods generally are cow milk, the peanuts, and sometimes the fish, etc. And the nuts are very common that one has to keep in mind. Medication, the drugs, also when we take them, they can react acutely and produce this kind of urticated reactions. The bites, especially the bee and venom, can also be responsible, and so is the wasp. Vaccinations can be responsible, and also the acute contact allergy due to latex. So in other words, these are some of the causes that do cause this urticated reaction in a true allergic manner. On the other hand, non-allergic is generally either histamine liberators, that there are certain drugs which can liberate histamine, for example codeine, morphine, vancomycin, and even the radio contrast media, and they can lead to acute reaction but in a non-IgE mediated manner. The second way is histamine, that there are certain foods which contain histamine, for example the orange, lemon, strawberries, tomatoes, pineapple, etc. They have got a lot of histamine, and they themselves leads to the urticated reaction. The third one is pseudo-allergy. When we say pseudo-allergy, that means it is not a true allergic reaction, rather it is an intolerance. And because it is an intolerance, so it is a dose related. Small dose may not cause a problem, but the heavy dose can lead to this kind of urticated reaction. So now the main topic is the chronic spontaneous urticaria. We also used to call it as a idiopathic. Idiopathic means we do not know the cause for it, so we gave this name. But now with all the facility available, we do know that 60% of these patients, they do carry some antibodies in their system, and that is called autoantibodies, and they leads to this reaction in our system. And how there is no one test clinically available in a routine clinic, but we have got something to do to establish that yes, there is a autoantibodies present, and that is by autologous serum skin testing, that we take some serum from patient's blood, prepare serum from that blood, and inject 0.5 ml into the skin, and if there is a reaction, wheal formation, we take it as a positive. Similarly, that these patients, they do react because of the various physiological causes, and we call it as a inducible urticaria. That means we can induce urticaria by various physiological factors like dermographism. That means small minor stroke can lead to the whealing formation, and when it becomes symptomatic, that means patient is uncomfortable even with their clothes rubbing, and this becomes a problem, and that comes about 5% of these patients, which we call it as a symptomatic dermographism. In addition, the heat, the cold, sun, exercise, vibrations, stress, all these factors can cause this problem of chronic spontaneous urticaria. At times we do come across chronic abscesses, chronic infection like dental abscess, like sinusitis, like gallbladder infections, or Helicobacter pylori is another in many series have been found to be responsible for this chronic spontaneous urticaria. But in sometimes these lesions obviously are not anything to do with these causes, rather they are due to the deficiency of C1 esterase inhibitor. That means there is an enzyme deficiency in their system that can be hereditary type or can be acquired type, and we call it as a angioedema, and they present less wheal formation and more swelling on their skin. And that is how it is very important that when we see these patients, proper history and examination needs to be done. So there are some investigations in these patients. In the acute cases, we do some skin allergy tests. We also do some blood tests in the form of RAST or immunocap tests to find out the specific antibodies against the allergens, and accordingly then we treat them. In addition, but these are not that important in the inducible urticaria or chronic spontaneous urticaria. So in these patients, normally we do CBC, we do ESR, we also do ANA, we also do some complement C3, C4 and C1 esterase inhibitors. Sometimes we obviously needs to be doing skin biopsy to rule out urticarial vasculitis. If the urticated lesions or the wheals, they stay more than 24 hours, then there is a chance that it may be immunological cause and may be a part of the lupus erythematosus. Sometimes these patients are associated with thyroiditis, so thyroid antibodies needs to be done. So in other words, when we are examining these patients, it is very important that we investigate them, examine them and then treat them, so we know what we are doing and give the patients full benefit. Now, as far as the treatment is concerned, the treatment in all the cases generally is first line of treatment, which is the second generation antihistamine, which are long acting, non-sedative, and it crosses the blood-brain barrier very minimal. So drowsiness is not there. So there is many benefits of using this kind of antihistamine. And number two is second generation. Sometimes these patients do not respond to them, so we can either increase the dose and get desirable results, or we add some systemic steroid with it, and that's how we can get some response. But there are always certain patients who do not respond to this treatment either. So in these situations, we give immunosuppressive treatment like cyclosporin, like azathioprine. Sometimes we give methotrexate also, or various other treatment available to get the desirable results. The fourth one, line of treatment, when we are really do not get any response with the available medicine, is biological treatment. Omalizumab is available now. It is very expensive, so we don't use as a routine, but it is available in a very dreadful, serious cases to use, or where the serum IgE level is very high and we want to reduce this level. In addition to that, sometimes we do use some IVIG immunoglobulins with a good response, and so do use narrowband ultraviolet B wavelength therapy, which gives us desirable results in some cases. So in other words, one has to really think what we are dealing with, because most of allergic or urticated reactions takes place via histamine, but sometimes this is the bradykinin which is released by the basophils, and they obviously playing a role. So one has to really decide, if antihistamine do not work, then what else? And in cases like acquired hereditary angioedema, we do get response with stanozolol, and which is a drug of choice, and ordinary antihistamine they do not work. And same is true for urticated vasculitis. So we do use some HCQS as well as combination of systemic steroid to get the desirable results. So in other words, this disease has got various aspects. All urticaria or chronic spontaneously urticaria are not IgE mediated true allergy. So one has to keep that thing in mind and treat these patients accordingly. And when we say food allergy, again remember that all food allergies are not a genuine IgE mediated allergy, rather most of the time this is a pseudo allergy or food intolerance. So if you remember that, I think we can deal these patients in a much better way. Thank you very much indeed.